Hi, good afternoon. Thank you for joining today's presentation hosted by the Sudden Arrhythmic Death Syndrome Foundation and Invitae, entitled Diagnostic and Therapeutic Approaches to Long QT Syndrome. Before we begin, I have a couple of housekeeping items to mention. First, please feel free to submit questions to Dr. Ackerman anytime during this presentation by typing them into the questions pane of the control panel and clicking send. We'll collect these and provide them to Dr. Ackerman during the question and answer session at the end of today's presentation. Today's webinar will be recorded and will be available for later viewing on the SADS Foundation website and as well as Invitae's website. With that, I'd like to now introduce today's presenter, Dr. Michael Ackerman, who is the Wendland Smith Rice Cardiovascular Genomics Research Professor and Professor of Medicine, Pediatrics, and Pharmacology at the Mayo Clinic in Rochester, Minnesota. He is a consultant in cardiovascular diseases and pediatric cardiology and serves as director of Mayo Clinic's Long QT Syndrome Genetic Heart Rhythm Clinic and the Wendland Smith Rice Sudden Death Genomics Laboratory. Dr. Ackerman, we thank you for your participation and presentation today and have been looking forward to it. And with that, I turn it over to you, sir.
Great. Thanks a lot, Dr. Callis. Thank you. And good afternoon, everyone, and welcome to this. I'm really looking forward to our hour together as we look into some of the diagnostic and therapeutic approaches to long QT syndrome. So thanks for choosing to spend your hour with us at the SADS Foundation. And we at the SADS Foundation are particularly thankful to Invitae for their unrestricted education grant that is enabling us at the SADS Foundation to put on this webinar. You also see my other conflicts of interest to disclose. I don't think they're going to affect my ability to talk about the subject matter. More important to disclose is, as you see here, my relationship with the SADS Foundation. I've had the privilege of serving as the president of the board, and on behalf of Alice Laura, the president and CEO of the SADS Foundation, just want to add a welcome from her. So get to know us at the SADS Foundation. Connect your families with life-threatening genetic heart rhythm conditions to the SADS Foundation. We can help you in the care of these families. Over the next 30 minutes of my monologue, we're going to cover three things. We're going to look into the phenotypes of long QT syndrome from a diagnostic and a therapeutic perspective. We'll consider and critique some of the various diagnostic modalities and try to understand their limitations. And then we'll turn the page and assess what are the currently available treatment options that we utilize as we personalize the therapy of our long QT patients and their families. And truly, this is an area where we get to practice true individualized medicine. But I'd like us to also look at what is the efficacy of these various treatment modalities. Long QT syndrome is the prototypic genetic heart rhythm disorder affecting about 1 in 2,000 individuals, and this is really one of those incredible syndromes, and those of you out there who have the privilege of taking care of these families know exactly what I'm talking about. It's an exciting syndrome. It's a challenging syndrome. They may or may not show QT prolongation. They may or may not ever have a torsadogenic experience, and so making the diagnosis correctly and risk stratifying them appropriately so that we can tailor their therapy is quite key. We're now almost 60 years since the birth of this syndrome from the sentinel description in the late 50s. The discipline of the cardiac channelopathies is now a young adult, over 20 years old since Mark Keating discovered for us the root cause of long QT syndrome with loss of function mutations in the voltage-gated potassium channel shown here and leaky sodium channels not shown. Those discoveries in 1995 then ushered in the decade of so-called research-based genetic testing. Some of you out there on the line participated in this time period, and you refer to this era a bit disaffectionately, I might say, as the black hole, the time and place where samples went and nothing came back. And as we all know, this technology matured for long QT just like it had previously for cystic fibrosis genetic testing, BRCA genetic testing, and so forth, to the first commercially available long QT test about 12 years ago. New problem, increasingly available, and then continue to be denied. And that landscape of insurance reimbursement has steadily changed over the years, which created another problem. Increasingly available, increasingly covered, and then increasingly utilized by relatively clueless users. And we only are in the first 5 years of having some sort of guidance as to how should we, the community of cardiologists, use genetic testing for these genetic heart rhythm and genetic heart muscle disorders. And 3 years ago, we had the latest consensus statement on the diagnosis and management of patients, and this is a document that you should be acquainted with. So when we think of long QT syndrome, and we're going to start with the diagnosis, the consensus statement says that you and I now render a diagnosis of long QT syndrome in a patient when their score is greater than 3.5 or equal to that, and you and I cannot blame away the QT prolongation with an acquired factor. Or we have a pathogenic mutation that's irrefutable, then they have a straight line to the diagnosis of long QT syndrome. Or if we incidentally come upon a patient who repeatedly has a QTC above 500 milliseconds, and again, we can't blame it away. We're tempted to render the diagnosis at softer QTC criteria, as shown here with the 480 to 499, but know that when we do it in this setting, there is going to be a significant number of false positives and erroneous diagnoses, and we'll touch on that shortly. So that Schwartz score, which is back, is this greater than equal to 3.5 points, where here are some of the points: ECG points, story points, and family history points. And by the criteria, when you have at least 3.5 points, that's registered as high probability that the diagnosis of long QT is correct, and I agree with that. The problem is the 1.5 to 3 point individual that prompts a designation as intermediate probability. By the end of this hour, I want to make sure that everybody recalibrates themselves that when we say Schwartz score equal to 2, intermediate probability, we're really talking about a 10% probability of having long QT syndrome. So the vast majority of patients who have an intermediate probability score by this criterion do not have long QT syndrome. Well, let's start with the diagnostic features and the most important one, and that is not the ECG, it is the story. The story is king or queen. The bottom line, story is the most important because it sets the stage for your and my index of suspicion. So when it comes to the story, as the starting point, we need to be sizing up the spell. When we hear a story, what you and I are doing, because the vast majority of our patients do not have a pre-installed loop recorder for story and rhythm concordance, is we're picturing what is the rhythm of our patient at the time of their spell. If we think it is a blow-off vanilla faint because they were in sinus rhythm, that story should not advance the diagnosis. If we are perceiving an arrhythmia as precipitating the event that's being described, then we amp up and we aggressively pursue the possibility of long QT syndrome. So the story must start everything, and the story not only is predictive for the diagnosis but also for prognosis. So this leading scientific journal, Glamour, got it right when they told us not to blow off a blackout. And we know that when you and I sized up the faint as being a concerning faint, an arrhythmia sounding faint, that was not only a harbinger of a future faint, but a future tragedy. Nothing come close to the hazard ratio as this, except for being trumped by having cardiac arrest. A QTC, the next strongest risk factor, for example, of 500 only has a hazard ratio of about 2 to 3. So as clinicians, as phenotypers, we need to assess the story, and the penalty box story is the patient who has an exercise-triggered faint, an auditory-triggered faint, a postpartum triggered faint, or seizure. And I need all of your help to help remind our neurology specialists that when you have a exertional triggered full body seizure, we must consider the organ south of the brain. The number of long QT patients, including the one I just saw this morning, who had been previously diagnosed and treated for epilepsy, continues. So don't blow off the blackout. I urge us to be phenotypers, to be a detective, to ask the who, what, where, when, and why about the spell so that we can calibrate our index of suspicion. How much is that spell moving us from the patient's 1 in 2,000 probability of having this entity by virtue of being alive? And then, when we sized up the feint, we need to act accordingly. We're not doing a great job, to be honest. This is still a recurring theme. In our program, we looked at this 9 years ago, and it's unfortunately continuing. Over 40% of the patients that came to Mayo Clinic with a diagnosis of long QT syndrome, rendered, I might add, not by family docs or pediatricians or psychiatrists, but rendered by pediatric heart rhythm doctors and adult heart rhythm doctors, they left without the diagnosis, the vast majority being dismissed as normal. The number one reason? Overassessment of an ordinary feint in the context of a oh-so-borderline QT value. We're going to have to look at that borderline QT value. That was the number one reason for premature and erroneous diagnosis that we reversed and removed. The second was committing the sin of QT inflation secondary to U-wave inclusion, and we'll come to that as after we leave the story, we then start the tests. When we start the test, we're talking about the 12-lead ECG as the starting point, not genetic testing as the starting point. And you can see from the Schwartz score that you can accumulate a fair number of points from the ECG. A QTC of 461 milliseconds already places you by itself as intermediate probability long QT. That's going to be wrong 90% of the time. Please, let's not forget that part. But you see those numbers, and we're going to come back to the numbers. You see the recovery QTC, documentation of torsades, and so forth. So let's look at the ECG. Everybody agrees? Long? Hearing silence, I agree, everybody agrees. This is really long, and it's really wrong out of our ECG reading room. This is how it came out of Mayo Clinic's ECG reading room, and it was not corrected. I love using this ECG as a reminder that the QTC by computer is accurate plus minus 400 milliseconds. Now, when we chuckle about that, we should be well aware that the truth is the computer probably outperforms us, the cardiologist. The computer gets it right about 90 to 93% of the time. It's just that 7% where it's wrong, it can be 400 milliseconds wrong. My good friend Sammy Viskin a decade ago said, how do we do? Oop, not so well. And I'm going to give you a few nuggets to make us better than the majority of cardiologists who get it wrong. We have to return back to the basics and size up the ECG to see if our QT agrees with the computers. And to do that, we need to do the so-called teach the tangent or the avoid the tail. And in doing so, construct your isoelectric segment, go down the downslope of the T wave and intersect the end of the T wave there, and refuse the urge to take it way out there, including this U wave, which is going to cause a significant overdiagnosis of long QT syndrome. So we're going to have to deal with the length of repolarization, but also the look of repolarization. So we have, here's this length. This would get you 2 points. But what about the look? And you would make the look of LQT2, and if you said so, you would be spot on. And what makes it LQT2 looking? This kind of abnormal notched T-wave contour out in the lateral precordial leads. So we have to do what Peter Schwartz once said when he said, I don't measure the QT interval, I look at it. So we have to deal with the length and the look. So here's a few nuggets to make us better than the 3/4 of cardiologists and even better than the 1/3 of heart rhythm specialists. I'm going to give you 5 pearls and then a bonus. First, use lead 2 and V5 there at the bottom. Then put your eye or your caliper on that rhythm strip QT interval as shown at the bottom, and then see, is your QT interval matching the computer's? If yes, you've confirmed the QTC because the computer is is good at doing mathematics. If it doesn't, then you have to ask yourself, why are you getting a QT interval differently than what the computer censored? A quick on the fly, if your QT is less than half the RR, it'll always calculate to less than 460. That doesn't rule out long QT, of course, but it's less than 460. Be careful with sinus arrhythmia. Be careful with atrial fibrillation. Don't do maximum QTs and minimum RRs. That's going to grossly inflate the number. Take the average across that rhythm strip. Again, in sinus arrhythmia, the computer does a great job of deriving an average heart rate in that rhythm strip to then derive your average RR. Remember, the patient's QTC reality breaks down at both ends of the heart rate spectrum, underestimating its truth at bradycardia and beginning to overestimate at high heart rates. Although we almost never see a long QT patient with a wide QRS, this is often asked, what do you do in the setting of a wide QRS, whether it's for a bundle branch or a PACE or whatever, and there's all kinds of formulas out there. I think you can do it really easy with a simple wide QRS adjustment shown here. Make sure that you agree with what the computer called the QT, to know that the QTC was adjudicated by math correctly, but then subtract and normalize for normal depolarization, and then you can get your wide QRS adjusted QTC without having to remember JTC normograms and so forth. So now with that tutorial, you have to decide which length of repolarization is actionable. And you saw the points that get mounted up by the Schwartz score. 480 gets you 3 points. 460 gets you 2 points. But what is the distribution of this metric of repolarization in health and in disease? And I think this is one of the most misunderstood biological parameters that we have in cardiology. Shown here is normal post-pubertal men and women, and then all of my long QT patients, where you can see the average is a Schwartz score of 3, 480. Out there, really long, not an intellectual dilemma. 600 millisecond used to be the line of high risk, and it's true, but you'll hardly ever see that. Then it was moved to 550, and now the line you must remember in your practices is 500. Not only is that the line of an incidental discovery of long QT that you've moved into, it's also the line of proarrhythmia. So never forget the 500 millisecond line. We have this challenge, though, of course, right, is the growing population of normal QT interval, long QT syndrome, or as we call it, concealed long QT syndrome. And you can be really concealed. That's our record, 365 milliseconds. But juxtaposed against that is the 440 line in the population, which has been ascribed borderline. And then we leave the word borderline, which is appropriate to about 10 to 20% of the planet. And now we have, by sanctioned guidelines, 450 in men, 460 in women, and remember, those start to get you risk score points. Those equal a guideline definition of prolonged QTC. But please remember that satisfying a guideline definition of prolonged QTC does not equal the diagnosis of congenital long QT syndrome. Well, I correct myself. Actually, it does, just less than 1% of the time. So we have to be calibrated correctly about the length. So with this part of the diagnosis, never forget the 500 line. If you cannot blame it away on an acquired factor, you have stumbled into long QT syndrome with a greater than 50% probability when they started before the ECG at a 1 in 2,000 probability. Then I think pause ECG thresholds are 480 in women, 470 in men, and 460 before armpit hair. These are the respective 99th plus percentile values in those age and gender groups. They do not equal the diagnosis of long QT syndrome, even though they got you 1, 2, or 3 points on the score, but they have moved that patient from about a 1 in 2,000 chance to about a 10% chance. So this entity clearly is worth looking into, but we shouldn't be calling these people long QT syndrome. And you already saw that you can have really normal QT intervals like this one, and yet they have long QT syndrome. So another thing that we need to help stop happening is the phrase, we don't need to do long QT genetic testing in you, Mr. Family Member, because your ECG is too normal. The only thing that can rule out long QT syndrome in an established family with long QT syndrome is a negative genetic test. So we must move on then in the index case where we're suspicious, or in the family members where it's already been established, with genetic testing, which will be the third and the final component of the diagnostic evaluation that we'll consider in this initial comment. Make no mistake, the genetic test has the greatest impact across the triad of medicine in long QT syndrome compared to all of the other genetic heart rhythm and heart muscle disorders. And the guidelines are rather straightforward. If you and I suspect this diagnosis, it's a class 1 recommendation to obtain comprehensive or targeted genetic testing. It's also recommended in the patient where we have stumbled into an incidental ECG finding in the otherwise asymptomatic patient, and you see the thresholds advised here, greater than 480 pre-puberty, greater than 500 in adults. Why those numbers? Again, because the math argues for now stumbling into this 1 in 2,000 disorders. The thresholds were softened and it may be considered at lower QT cut points, but again, when you start genetic testing in these territories, you will have a significant number of false positives, and the VUS issue of genetic testing will rear its head. And as we showed earlier, for the rest of the family, mutation-specific genetic testing is a class 1 recommendation when we have found the cause. So we could do comprehensive testing, all of the genes known. The guidelines also said it would be reasonable to just focus on the big 3, as the big 3 account for 75% of the syndrome. And we know a lot about the 3 major LQTS genotypes. LQT1, the most common, 1/3. LQT2, second place, conveniently so, at 25 to 30%. The sodium channel version of long QT syndrome is in 3rd place at about 5 to 10%. And then we have the minor players that, frankly, LQT5 and LQT10 and LQT17 are all minor, so we're not going to consider them right now. The 3 major genotypes have their characteristic storylines. There's gene-suggestive patterns, wide-based T waves in 1, hump, bump, notch in 2, normal-looking T waves after a long isoelectric segment in 3. They have their triggers, activity, exertion, aerobics, and swimming in type 1, auditory triggers in type 2, the postpartum period in type 2, and non-activity in type 3. And what distinguishes long QT genetic testing from virtually every other genetic test in the heart disease space is that you and I tailor therapy in a gene-specific way, because there is clear gene-specific responsivity to our mainstay therapy, which we'll talk about shortly, the beta blockers. They work great in LQT1, quite good in LQT2, and the new word on the street, as confirmed this year in the largest circulation paper of LQT3 patients, led by Arthur Wilde, is that yes, they do work in LQT3. They reduce event rates, probably close to the level of efficacy in LQT2, but nowhere as close to the efficacy as in LQT1. We need to remind ourselves, and it's a subject for an entire future webinar, is the Achilles heel of genetic testing, which is how certain are we that we have found our patient and their family's true disease-causing mutation. We're going to need to get used to the maybe test result, and I don't think we're doing very well with it as a community of ordering physicians. They come coded as possible deleterious, as variants of uncertain significance. For now, let me just tell you, it's a scary place that I've called genetic purgatory, and we're going to have to wrestle with and understand the probabilistic nature of genetic testing, just like we need to have a better handle on the probabilistic nature that comes with a QTC of 479 milliseconds. Well, that was the main part of our 30-minute monologue, and in the remaining 10 minutes of mine, before you have your questions that we're going to entertain, and again, if you have any, please jot them down, and Dr. Callis will then soon take them in the next 10 minutes. So let's turn our attention to some of the latest treatment strategies for the patient that you and I are comfortable and confident in the diagnosis of long QT syndrome being the correct diagnosis. Regardless of genotype, regardless of expressivity, we must do the simple, good old-fashioned QT drug avoidance recommendation. The number one way to take an asymptomatic 40-year-old with long QT to a sentinel event dead 40-year-old is to have them be exposed to medications on the QT hit list. It is important. These patients do not need a stat ICD. They need a list of the medications to avoid. They need to be counseled about potassium and electrolyte replenishment. They need to be offered fish oil supplementation if they're into complementary alternative medications. It might help. It definitely won't hurt. Then we have our primary options as shown here. Drugs on the left, devices on the right, and denervation in the center. I need all of your help listening today to get out the word that the vast majority of patients with long QT syndrome do not need and should not get an ICD. There's an overzealous utilization of ICD going on out there, particularly in the United States. And while most of them only need beta blocker therapy, we are actively pursuing and trying to figure out in which patient is even beta blocker therapy over therapy. Because beta blockers are not innocuous, and if you've ever thought they are, go ahead and put yourself on 60 milligrams of Nadolol and see what you think about your quality of life. Many tolerate it beautifully, but we should be trying to figure out who is at so low risk, like the person shown here, where we may not need anything but the preventative measures. But for the most part, it is beta blocker therapy. And the beta blocker therapy that is the beta blocker of choice among the largest long QT centers throughout the world, and I know of almost no exception to this statement, is the non-selective beta blockers of Nadolol or propranolol, and with most liking Nadolol the best. There's an equivalent dislike among those centers for the beta-1 selective beta blockers of atenolol and metoprolol, and I would certainly be one to, as loudly as I can, in the absence of randomized controlled trials, discourage the use of these beta blockers. For LQT3, we probably are converging on combination drug therapy with propranolol as the beta blocker of choice and mexiletine as a late sodium current blocker. What about on the other side? Who then should get an ICD? Well, if you've had cardiac arrest, everybody agrees. If you've broken through your beta blocker or you hate beta blocker, it's a class 2 indication, although I would argue that denervation therapy in that setting has far fewer comorbidities than an ICD placement does. What about predicting the future? In the asymptomatic, when would we go maximally aggressive? The 2013 statement is rather silent, but I'll give you a few suggestions. When the QTC is really long, over 550, and they're not LQT1, I would fully support going ICD aggressive. And you don't have to wait for them to get above 550 when they're an LQT2 post-pubertal woman. That profile is the single highest risk group of experiencing a sentinel event in the space of long QT syndrome. Importantly, the last two must come off the screen. We have to stop using family history of sudden death as a personal risk factor for an ICD decision. It's not a personal risk factor. Emotional, yes. Evidence, no. And the reflex between LQT3 and ICD is lightning fast, and we need to try to slow that down. Last, between drugs on the left and devices on the right, we have left cardiac sympathetic denervation surgery, and I want to try to put it in its appropriate place about its efficacy. This is not a new therapy. It is almost 100 years old. It is 100 years old, and it's over 45 years old for its first use in patients with long QT syndrome. There is no doubt about its antifibrillatory effect in long QT syndrome. I think, and we have evidence that that antifibrillatory effect is greatest in LQT1, followed by LQT2, and perhaps less in LQT3. The effect is probably mediated by localized norepinephrine ablation. And as many of you know, we have assembled the world's largest experience with providing denervation therapy, and we're approaching our 200th denervation shortly. The vast majority of these 188 patients have been long QT syndrome, with 137. Who gets denervation therapy for long QT, or who should? I think there's two populations. If they've had appropriate VF terminating shocks, we should stop telling them that's why they got the box and just continue. We need to try to work really hard to make the next shock as unlikely as possible. And after one appropriate shock, we're thinking about candidacy for denervation. As mentioned, if they hate their beta blocker or they just had a faint on beta blocker, I think denervation makes far more sense than a prophylactic ICD. And there are times when we know the risk is high, but we're just not enthusiastic about going directly to an ICD because of body size and device-related issues. So this brings us to the end of the monologue, and I hope you have a series of questions that we can entertain together for the next 20 minutes or so. And I want to leave you with 4 take-home points as a springboard to our questions. First, remember to be a detective. Avoid the tails, in other words, exclude the U-ways, and take careful stock of the patient with a QTC above 500 milliseconds. You've likely stumbled into long QT syndrome if you can't explain it away, and you've stumbled into a long QT patient who's at significant risk for a subsequent long QT triggered event. Second, remember that genetic tests are probabilistic tests and that X does not always mark the spot. Third, most do not need and should not receive an ICD. And last, remember denervation therapy and its antifibrillatory effect. Don't just let the ICD keep firing. So as you think about firing your questions to Dr. Callis, just want to encourage all of us that whether we're a phenotypic detective sizing up the story or interpreting the ECG, we need to be careful users of these tests, including the use and the interpretation of genetic testing, so that in doing so, we can make wise decisions about these incredible families that you and I have the privilege of caring for, and so that we then prevent, tailor, individualize their treatment program to minimize the chance of long QT triggered fainting, seizing, or ceasing. So I want to just recognize quickly those entities in our program at Mayo Clinic that enable us to try to fulfill the mantra of Mayo Clinic, which is to heal the sick and to advance the science, especially Wendy's family. So I'd love to entertain any questions. Thanks for choosing to spend these first 35 minutes with us, and Dr. Callis is going to now lead us into the question and answer conversation section. So thanks again, everyone.
Thank you, Dr. Ackerman. Yeah, just as a reminder, there is a questions pane in the control panel of the GoToWebinar, and just enter your questions in and click send, and we'll get them. And I'll be reading these questions in the voice of the attendees. They're not necessarily my question. So Dr. Ackerman, for infants and children, is Nadolol more effective than propranolol?
That's a great question. I don't think we can conclude that Nadolol or propranolol, that one is superior to the other. And I have no problem using liquid propranolol in infancy with the initial diagnosis. Increasingly, I've started to use liquid Nadolol just because of the pharmacokinetic convenience to do it twice a day, whereas liquid propranolol must be done 3 times a day. But often we will start with liquid propranolol, and I view liquid propranolol and Nadolol as being equal effective, and I don't think one could claim a superiority of one of those over the other.
Great, thank you. Do you adjust dosage of Nadolol based on corrected QT on subsequent EKGs, or just heart rate response to exercise or Holter monitor?
Yeah, so the question is, how do we adjust to be satisfied with the degree of Nadolol or the level of beta blockade? I don't think we do it based on what the beta blocker does or does not do to the QTC. There may be a mild QT attenuating, shortening effect with beta blocker therapy. I think that is pleasant to see, but not a prerequisite of effective beta blocker dose. I tend to try to get to a targeted dose by weight. So for propranolol, if I'm concerned about the risk, I'm aiming for 3 to 4 milligrams per kilo per day. For Nadolol, if I'm concerned about the risk, I'm aiming for 1 to 1.5 milligrams per kilo per day, divided twice a day for the first decade, and then move to once a day thereafter. I use the stress test to get a gauge that the patient is developing physiologically detectable levels of beta blockade by virtue of a chronotropic effect on their stress test. But there is not, emphasize not, a magic level of chronotropic suppression to where you would say, okay, they're 20% blunted on their peak heart rate before and after beta blocker. I've reached the curative threshold of chronotropic inhibition. I just like to see a 20% plus reduction in peak heart rate to know that I'm not dealing with some sort of peculiar ultra-rapid metabolizer, and that on that targeted dose of medicine, I'm achieving a measurable effect in terms of physiologic readout.
Do you think the compliance with propranolol, more frequent dosing, is less than with Nadolol?
I think compliance with beta blocker therapy is multifactorial in terms of just the amount of time and how it makes you feel. There's well-established studies that compliance with 3 times a day medication is inferior to once or twice a day. So there is a compliance advantage when you only have to do a medicine once. I think the other factors in compliance really is education. How well have we done in communicating to the families that the beta blocker is incredibly important, that haphazard administration of the beta blocker, in other words, non-compliance, is the single greatest risk factor for a recurrent or breakthrough event. And in fact, one could argue that haphazard dosing of the beta blocker could actually elevate their long QT severity beyond what it might be had they never been on a beta blocker. So I think if you set the stage as to what the purpose of the beta blocker is and how life-saving it is, you then will have a better opportunity of achieving the compliance that you aim for. We aim for, on a once-a-day Nadolol, accepting 1 dose a month being missed as doing an outstanding job.
Dr. Ackerman, what is your typical order of diagnostic tests in patients with a borderline asymptomatic corrected QT?
Yeah, I think, again, if so asymptomatic, and we've stumbled into a QTC that's not diagnostic. My view is I try hard to be a minimalist in that setting, so if there is no story driving it, and all there is, let's say, a prepubertal who exceeded that 460 line in the sand that I drew, and they have a 463, I ask careful questions about the story, and if indeed there is no personal story and there's no family story, I usually try to do 3 things. 1, repeat the ECG on the patient, and 2, get ECGs on the mom and dad, so that makes a total of 3. And if that patient's follow-up ECG drops below that 460 cut point, I'm rapidly working, and the family ECGs are also below their respective cut points. I rewind the clock quickly and dismiss this as a non-specific, non-diagnostic QT that's not worthy of further attention. So I don't do much. So I don't think the quote-unquote borderline value, in the absence of something that moves the needle, should be spent with much extra testing. They definitely should not get genetic testing. The noise in the genetic tests will explode the system in terms of the interpretation, and they'll end up with a non-diagnostic story that should have kept them at 1 in 2,000. a non-diagnostic ECG that should have not moved the needle, and then a variant of uncertain significance. If there's anything about the follow-up ECG or the story I'm not liking, then I commence the full court press. And once I commit to a long QT evaluation, it really is the whole enchilada. So it's going to be repeating the ECG, doing a treadmill stress test, maybe doing an epinephrine QT stress test, although we do that less than what we did when we first described that new test over a decade ago. Doing a Holter, although only using it for incidental arrhythmia detection. I think you have to be really careful of making a QTC diagnostic pronouncement based upon the percent of the time that the QTC is above 450 milliseconds. I think that is probably the third most common reason for our overdiagnosed long QT that we then reversed and removed the diagnosis of. And then last test is the genetic test. So once I'm bothered enough, we would do the full court evaluation of those tests. But no story, no family history, and an incidental 462 in a 9-year-old or an incidental 481 in a 33-year-old woman, we would be just repeating those tests and to try to reverse course promptly.
Great, thank you. Is there any advantage of a Holter to measure the QT interval over a resting EKG or stress test?
Yeah, I think eventually there's going to be, but I think right now there's been so many diagnostic miscues with the QTC value obtained during Holter monitoring that we just don't know its performance characteristics. So I think right now it's resulted in far more overdiagnoses rather than gotcha moments where it's been the Holter finding that's caught or unmasked a long QT patient. The far better unmasker of long QT patients is the treadmill stress test and the epinephrine stress test, because there at least we know what's the positive predictive value of a finding when they are QT normal at rest, but they show abnormal repolarization during the stress test or during the epinephrine infusion. Where with the Holter, I just think that we don't have a good handle on what is the QTC metric, like we showed, on those Gaussian curves, really, for what is essentially an 8 a.m. in the morning 12-lead ECG. We just don't know what that looks like in a 24-hour cycle. And there's some interesting stuff coming out. My friend and colleague J.P. Koderek in University of Rochester, New York, has published things like the QT clock. And I think in time, the ambulatory QT assessment is going to be helpful. But right now, I think the balance would be tilted towards Holter-mediated overdiagnosis rather than Holter-proven gotcha diagnoses.
Dr. Ackerman, if an undiagnosed patient presents with cardiac arrest and is then diagnosed with long QT, do you initiate beta blockers alone or beta blockers plus ICD? Your slide indicated cardiac arrest as an indication for ICD.
Yeah, I think most long QT specialists throughout the world would agree that aborted cardiac arrest, regardless of the genetic heart condition, gets you an ICD, period. Now, some could contend, and I'm one of those who I think I could make a reasonable argument that if that aborted cardiac arrest occurred in an undiagnosed and therefore untreated LQT1 patient, for which beta blocker therapy with or without denervation would be exquisitely protective, that maybe we would not have to go immediately to an ICD. And in fact, we've done that in our program. There's been a handful of patients where we have not committed straight to an ICD because their portal of entry was aborted cardiac arrest. But for the most part, in 2016, soon to be 2017, an aborted cardiac arrest, regardless of genotype, kind of takes you to a secondary prevention ICD.
Great, thank you. Going back to the question of Holter monitoring versus resting EKG and stress test, what do you think the false positive rate is for the stand QT test?
Yeah, so the stand QT test has been popularized and first published, I think, by Sammy Viskin and Arthur Wilda, and I'll be interested to see what the false positive rate is of that. In our own program, I've seen a pretty high false positive. So I don't really use it, to be honest. I use the QT performance characteristics during the stress test, particularly during the recovery phase. And I find, a QTC above 470 milliseconds at 2 to 3 minutes of recovery to be about 70% positive predictive value that you've unmasked and elicited LQT1. I think that the standing test is going to be less than that if one were to do a head-to-head comparison. Among the patients where we removed the diagnosis of long QT, there was a standing positive reaction if we're doing it the way it's been described. So one of the possibilities is we may just not be doing the timing of the standing assessment the same way that it was done in some of the original studies. But admittedly, I'm a bit lukewarm on the standing test.
Thank you. Dr. Ackerman, if I've already diagnosed my patient with long QT syndrome and I'm treating appropriately, what effect will genetic testing have?
Yeah, so I think that's a common question of, I've already made the diagnosis, I have no doubt about the diagnosis, why do I need the genetics? And this is where we have to encourage the cardiologists, adult and pediatric, that we have to start thinking like a family physician when we are dealing with genetic heart disease. So we may or may not modify our treatment program for that index case in front of us, but it is going to have a tremendous effect, judge and jury, guilty versus innocent, of all of the relatives. And that impact is tremendous. But I would also say that in long QT, which is a bit different than, say, hypertrophic cardiomyopathy, that patient's genetic status with long QT actually changes my therapy. So if I confirm LQT1, I'm going to be super confident with a Nadolol primary and Nadolol only program. If that patient is LQT3, I better be thinking about combination drug therapy. If that patient is LQT2 and she's a woman, I better be thinking, am I really confident in the treatment program, or do I need to go more aggressive with an ICD? So I think those of us who do long QT syndrome patients, we clearly are adjusting and tailoring our therapy when we have elucidated and established the genotype. So I personally think I need it to take better care of my index case, and I certainly need it to adjudicate the status of all of my index cases relatives, for which the ECG will never come close to the discrimination value of a mutation-specific genetic test.
Great. Right along with that question, how do you manage a family member who tests positive for their family's pathogenic variant but have no symptoms of the disease?
Yeah, so the management of the mutation-positive asymptomatic individual by guidelines has been pretty much a recommendation for universal beta blocker therapy. So if that asymptomatic individual's QTC was above 470, it's a class 1 recommendation for beta blocker. If that individual's QTC was below 470, it's a class 2 recommendation. So right now the guidelines argue for universal simply because we're not smart enough to know who is at such low risk that beta blocker is too much. In our own program, we recently have looked at this and hope that we'll be showing this at Heart Rhythm in May, of an intentional non-treatment program. And there we have about 5% of our 1,000 patients are being treated without anything. And obviously these are carefully chosen, carefully selected patients, but there the breakthrough event rate on nothing has remained nothing. So I think in time we might figure out which kind of genetic test positive patients, particularly the relatives, need nothing but the list of drugs to avoid.
Thank you, Dr. Ackerman. Dr. Ackerman, how often should we follow up with stable patients on beta blockade who are asymptomatic?
Yeah, that's a great question. I think the follow-up, as I've observed, must be somewhat related to whether the practice is salaried physician or test-driven. We take stable patients, we take high-risk patients, and we follow them yearly, and some of them we graduate. So the post-pubertal 25-year-old man and older, we've graduated them to an every 2 to 3 year evaluation. The prepubertal girl, we graduate quickly to an every other year evaluation until approaching puberty. So I think that the programs that are advising their long QT patients to come back for an ECG, Holter, and a treadmill every 3 months, there's something amiss in that formula. So while we're getting therapy built up and put in place and to where I'm satisfied that we've achieved what I call therapy cruise control, that might initially, during the first year of diagnosis, be an every 3 to 6 month evaluation, some of it remotely. Once we're on cruise control, it's at most a once a year reassessment.
Dr. Ackerman, do you know how many centers in the U.S. perform the left cardiac sympathetic denervation surgery?
Yeah, I know. I don't know the answer. I think long QT denervation surgery or CPVT denervation surgery is the same surgery. I view it as a boutique operation that should be done by a boutique operator, just like I view surgical myectomy for hypertrophic cardiomyopathy. Not every center, not every cardiac surgeon should be doing myectomy. Not every center should be doing the denervation. It is a bit of a nuanced surgery. I know that nobody comes close to the number that we've done in the United States. The other centers that I'm aware of offering denervation surgery would be Boston Children's. But besides that one, I'm not actively aware of those that offer it. UCLA, there's a program out there that has a denervation program for their ischemic VF population where they're thinking about bilateral denervation in a different patient population. But there they've achieved some experience with thoracoscopic denervation surgery. But you know, the vast majority of my patients come from my colleagues throughout the adult heart rhythm and pediatric heart rhythm community at you know, major centers, but have chosen that this particular surgery should be consolidated in centers of excellence.
Thank you, Dr. Ackerman. Well, we're close, but not quite to the end of our hour together, and we have run out of questions from our audience. So if anyone has any more questions they'd like to submit, we have a few more minutes.
And would love to entertain the final question, but I will, while you're thinking of a last one, let me bring you to the final slide as we come to the end of 2016. And I would invite you, if you've benefited from this presentation, to feel free to make a year-end contribution to this organization. We are really the only nonprofit advocacy organization devoted to families with long QT syndrome, with CPVT, with these genetic heart rhythm disorders. And we could not be doing the mission of helping them live and thrive and increasing physician and healthcare professional awareness about these conditions without your participation and support. So if there's any interest and desire, go to the website, and in the top right corner there's a Donate Now button, and we would welcome your donation.
Great. One last question. Can you tell us about the new late sodium channel blocker medications?
Yeah, that's a great question. Unfortunately, the news is not great. So the question is, what's the status of the new late sodium current blocker medication for long QT3 patients? This is a drug developed by Gilead Sciences. It's called aleclazine, and they are wrestling with whether to continue the advancement of this drug. They released publicly at American Heart Association results from the drug in a so-called Tempo VTVF cohort, which was the attempt to use this drug in patients with ischemic cardiomyopathy, average age 60, average EF 35-40%, with ICD, with a hope that it would reduce ICD shocks. And it did not. And in fact, those who were receiving aleclazine had about twice the shock burden as those who were receiving placebo. So with that signal, a potentially pro-arrhythmic signal in that different population, but nevertheless a patient population which would have been their large patient population, right, of ischemic cardiomyopathy with arrhythmia, the wind went out of the sails in a major way, and so the bandwidth motivation to continue the development of the drug in an orphan disease status for LQT3 has kind of evaporated, and so they are just making their indications be known as to whether or not they'll continue the drug's development, and it's tilted towards the or not. So it made great sense from a pathobiological standpoint, but it looks like we will not have this drug added to our armamentarium for the treatment of LQT3 patients. So for the foreseeable future, we'll be using propranolol with or without mexiletine, and in some mutation-specific settings, choosing other late sodium current blockers.
Dr. Ackerman, in our last couple of minutes together, I think we have one last question from our audience, and that is, at what age, if any, and in which situations may beta blockers be discontinued in long QT patients?
Yeah, the discontinuation of beta blockers once they've been started is going to be an interesting nut to crack, because we really don't know. I mean, because when you put somebody on a beta blocker and then they've gone an asymptomatic trajectory, has that been precisely because of the protective effect of the beta blocker, or was it 20 years of overtreatment because they had a minimally penetrant non-expressive substrate to begin with? So lifting the beta blocker becomes challenging. The approach that we take now is, if I would have never started it in the first place because of their low risk prediction, I have to be comfortable with discontinuing it. But I think we have a lot to learn to guide us as to when could you choose to stop it, because you've protected them through their vulnerable period of time. If it was a prepubertal boy, for example, and now they're 25, or do you need to start a prepubertal girl on it when their QTC is unimpressive? Could you wait 10, 12 years until you move into that more vulnerable window of time? So I think we still have a lot to learn in this area. That's a really important question and an important management issue that we haven't figured out.
Thank you, Dr. Ackerman. Well, we are at the end of our hour. I would like to thank our attendees for their participation. I would like to thank you, Dr. Ackerman, for sharing this information with us.
Yeah, thank you very much, Dr. Callis, and again, all of you there, thank you for choosing to spend the hour with us. And I hope you found value with it, and I look forward to working with all of you in any way that brings value to your practice. So wish you all the best, and take care.
Thank you. This concludes this webinar.